start. So thank you on behalf of Drug Free America and the National Drug Free Workplace Alliance for joining us today for our webinar. Oh, I hit the button too many times. Joining us today, hopefully it doesn't want to stay on the screen. If you have not already, please introduce yourself and your organization in the chat box as my screen catches up here with itself. And if you have any questions during our presentation, we do ask that you put them in the Q&A box. Dr. Donna will be happy to answer those as time allows. I do just have to give a little disclaimer that the content provided here is for educational purposes only, based on industry expertise. It is not legal advice, express or implied. Please consult legal counsel before acting or not acting on any information from this webinar. Presenter opinions may not reflect those of Drug Free America Foundation or the National Drug Free Workplace Alliance. Now it is my pleasure to introduce Dr. Donna Smith. She is a Drug Free America board member, has over 35 years of expertise in drug-free workplace policy and program administration. She has held key policies with the U.S. Departments of Army, Defense, and Transportation, helping shape drug and alcohol testing regulations. Dr. Smith is on the faculties of the American Society of Addiction Medicine and the American College of Occupational and Environmental Medicine, training physicians as medical review officers. She has served on SAMHSA's Federal Drug Testing Advisory Board and SAPA's board. She also works with impaired health professionals monitoring programs and holds degrees from Capital University, Hunter College, and Ball State University. All right, I'm going to hand things back over to you, Dr. Donna.
Okay, the moment of truth here, right?
Yes. All right, it looks good.
Is it there?
Yes.
Great. Okay, super. Again, I really apologize to you. I know it's horrible to try to wait, especially when we're over the lunch hour, noon hour, whatever. I'm really pleased to be able to present this material to you today because most of my professional life's work has been in the area of drug-free workplace programs and the promotion of those and essentially the evolution of them. So I did want to start today, and I hope it's not kind of boring for you, but I think that sometimes it really does help to have the history and to be able to look at how far we have come with drug-free workplace programs, and especially with those programs as they impact prevention, as they impact workplace safety, and as they impact deterrence and detection for drug use. So it does go back quite a ways. In the 1980s, we saw the beginning of drug-free workplace programs in the US. And in fact, there was a nonprofit alliance of Fortune 500 companies that put together a Institute for a Drug-Free Workplace program. And it was a pioneer in providing information to employers, to various stakeholders, et cetera, about the drug-free workplace issues. So that then probably, as we have been bombarded with the past month, if you will, executive orders. Okay, no stranger to the news cycles this month at all, but it was in fact an executive order number 12564 in September of 1986 that really birthed, if you will, drug-free workplace programs, and certainly in terms of in the federal government. And so that executive order by then President Ronald Reagan required the federal executive branch agencies, all those agencies, I think at the time there were 175 executive branch agencies. I don't know how many there are today, who knows, or how many will be left tomorrow, but at any rate, this executive order required those executive branch agencies to develop and implement drug-free workplace programs throughout the federal workforce. And all of those agencies had to submit their plans to the federal government to an interagency coordinating group that was formed, showing how they were going to adopt policies and programs that would foster drug-free federal workplaces. And I thought it was worth putting down here what, and even though it was so long ago in 1986, putting down what then President Reagan said. He said, drug use is having serious adverse effects upon a significant proportion of the national workforce, costing billions of dollars of lost productivity each year. He said that the federal government as an employer is concerned with the well-being of its employees, the successful accomplishment of agency missions, and the need to maintain employee productivity. So again, hitting at a lot or several of the areas that you all, I know, are familiar with in terms of what the goals and objectives are of your workplace, drug-free workplace programs. And then this was kind of the kicker when President Reagan said the federal government, as the largest employer in the nation, can and should show the way toward achieving drug-free workplaces through a program designed to offer drug users a helping hand. And so even back then, employee assistance programs, access for treatment was a key component of drug-free workplace programs. And at the same time, demonstrating to drug users and potential drug users that drugs will not be tolerated in the workplace. So that was Executive Order 12564. What I find is interesting is that over all of those years and the succession of presidents and administrations, there was never an executive order that rescinded President Reagan's executive order or that changed it or did whatever. And let's take a look then what happened after 1986. So it was just the following year then that Congress passed legislation known as Public Law 100-71 that was designed to make sure that there was uniformity among the federal agencies' drug testing plans, that there was reliable and accurate drug testing, that there was a protection for there was access to drug testing records for employees, there was a protection of those records from those who had no need to know, that there was a confidentiality of just drug testing results, and that was kind of what they what Public Law 100-71 put in place. And then it was about 2 years after that, in 1989. And again, I think this piece of history is particularly germane to what we are facing today in American workforces. In 1989, the DOT issued the first regulations requiring drug-free workplace programs in private sector companies in commercial aviation, rail, interstate trucking, maritime, and oil and gas line pipe operations. Employee drug testing was a major component of these requirements. And I want to point out, because of where we are right now with regard to drugs and drug use and the public's perception of illicit or illegal drug use, is that those DOT regulations that were first issued in 1989 were a direct result of the National Transportation Safety Board directing the Department of Transportation, specifically the Secretary of Transportation, to issue safety regulations that included testing employees for illicit drugs. And that was the NTSB directive to Secretary Dole was as a result of fatalities in rail, trucking, and aviation accidents that were directly attributable to what? Marijuana. Principally marijuana use by pilots, by aviation mechanics, by railroad engineers, conductors, and crew, and by commercial drivers of large vehicles engaged that were in traffic fatality incidents that had some kind of NTSB oversight. But at any rate, so this started, if you will, with marijuana as a drug that was impacting transportation safety. And I think it's very interesting now that we are 30 some years full circle to where marijuana, by many accounts, has been normalized as in our society, is seen as not a dangerous drug, is seen as a drug that does not appreciably affect safety, workplace safety, safety in transportation, whatever it may be. Again, just a little side note to kind of bring you up to date, I think, in terms of what's happening. You may recall that several months ago, I guess it's probably been now 6 months ago, the Department of Health and Human Services and the Department of Justice were directed by the previous administration to put out rulemaking to reschedule marijuana from a class 1 drug as a dangerous drug under the code for controlled substances, the U.S. Code for Controlled Substances, to reschedule it from that category to a category 3. Category 3 is the less dangerous category of drugs. They are not seen as having a potential for addiction or for dependency, and they are seen to have bona fide medical uses. And so at that time, the HHS conducted a study, the Department of Health and Human Services, Department of Justice looked at a legal review. They pulled in their agency under DOJ, which is the Department of the DEA, the Drug Enforcement Agency. And the conclusion was that, in fact, marijuana was not as dangerous as other drugs in the class 1, if you will. And so they recommended reclassifying it to a Schedule 3. Well, that created quite a stir. Certainly the marijuana lobby and certainly some aspects of the medical community greeted this with really good news, because they felt that marijuana, if it were a Schedule 3 drug, certainly more research could be done, certainly more use of it medically would result. It was unfortunate, I think, that the major thing that the Department of Health and Human Services relied upon concerning marijuana use and workplace, if you will, was that there were so many states that had, quote, legalized marijuana through medical marijuana programs and through recreational programs, and that those states had found, or at least they had indicated, that this was a drug that should be in the mainstream of medicine and that should be controlled similarly to how alcohol is controlled for personal use. So those regulations, as proposed to reschedule marijuana, came out just prior to, I would say they probably were published in October of this year. Then we had the election, and we have a change in administration that was going to be happening in January. And so the process for that rulemaking was somewhat stalled. There were to be a number of public hearings where experts in the field from both sides of whether marijuana should remain an illicit and highly controlled substance, or those who felt that it had a much more mainstream purpose and much expanded medical uses. And that public hearing, which was to take place December 1st or December 4th, early December, was in fact canceled after the results of the election. I don't know how many of you know this, and I'm trying to be very, very objective across the board, but the new Director of Health and Human Services, the cabinet member, the Secretary of Health and Human Services, of course, is RFK, Robert Kennedy Jr. And I don't know how many of you know that he is a man in recovery. He had a heroin addiction, had polydrug use, which of course began with what? With marijuana use. He is concerned that the marijuana available today is estimate the average marijuana strains that are sold on the streets or that are sold in dispensaries, et cetera, are over 10 times more potent in terms of the psychoactive cannabinoids that they contain than was true 20 years ago. And he feels very strongly that we need to really reevaluate this whole circumstance of where marijuana is as a drug in this country. So he's called for further study and specific research into the potency of marijuana, specific research to be provided to the Department of Health and Human Services and the Department of Justice, the DEA, with regard to marijuana. So I think it's it is interesting that we are kind of full scale or full circle again with regard to workplace and dangerous drugs and what we can do about it. There is no question that that fentanyl as an opiate drug has created havoc, if you will, not only in workplaces, but in public health circles. And again, it is probably approaching in terms of deaths, the figures, overdose deaths that we saw with OxyContin or oxycodone in the height of the OxyContin epidemic, if you will, the opioid epidemic. So it'll be interesting to see what happens from a federal perspective and what impact that has on drug-free workplace programs, not only in the federal sector, but in the private sector. So then in 1986, the Nuclear Regulatory Commission got on board with requiring nuclear energy facilities, all of them, to have drug-free workplace programs and to include as a component of those programs fitness for duty testing and fitness for duty assessment. So they really saw this in the nuclear energy industry, that the abuse of drugs, that the misuse of prescription drugs, that the misuse of alcohol in terms of reporting for duty with any alcohol in your system was a primary safety concern, safety and security concern. And so the NRC has since 1989 had fitness for duty regulations that are very comprehensive relative to the expectations of any employees that have access to nuclear facilities. All right. Going ahead, then in 1991, Congress passed the first Federal Drug Testing Act, if you will, separate from, again, the executive orders or the public laws that were aimed at funding various programs. And they passed Omnibus Transportation Employee Testing Act, or called OTITA. And that did expand those very novice and young Department of Transportation regulations that were issued in late 1989 under Secretary Dole. And they expanded it so that now the employers in all of the transportation industries that fall under the Department of Transportation for safety regulations were required to have comprehensive drug testing programs, comprehensive alcohol testing programs, and the expansion of the workers that were subject to those that were considered safety critical or safety sensitive included now mass transit workers, which were not included originally, intrastate trucking, not just over the road interstate trucking, but anyone who drove a vehicle on a public road, that vehicle required a commercial driver's license. So that was school bus drivers, that was delivery drivers, that was whatever. And so it really expanded the requirements with regard to those employers having a drug-free workplace program, having sanctions for violations of their policy, and including comprehensive testing. Then since 1996, the Substance Abuse and Mental Health Services Administration, which is SAMHSA, through the Division of Workplace Programs, has provided extensive resources for employers, both public and private. So whether that's, municipalities or state governments or rural coalitions of transit providers, whatever it may be, they have provided resources for those employers in developing and implementing drug-free workplace programs, including a drug-free workplace toolkit that serves as a resource for employers, large and small, really. And they try to update that and keep that pretty current with regard to the challenges that employers face in trying to facilitate a drug-free workplace. And then, of course, the one that you all are familiar with is that the community and industry drug-free workplace coalitions have been formed on the national, the state, and the local levels throughout the US over the past 2 decades. And there again, the emphasis as expressed in what we're doing today has been on education, on prevention, and on substance abuse treatment strategies. So, and always prevention is a difficult, what I call it's a hard sell, because people are very, very, and lawmakers, whether that's lawmakers, funding sources, etc., are very skeptical, if you will, about spending dollars for prevention. And yet we know that for every dollar that we spend in prevention, in fact, that dollar has a threefold return, if you will, in terms of being able to deter or mitigate, if you will, drug addiction in particular, and drug use, and ultimately saves treatment dollars. Okay, so what are the components of a drug-free workplace program? I'm kind of preaching to the choir here, I'm sure. I'm sure that you know these, but these again were first, I guess they were first elucidated in that original executive order and that original Public Law 100-71, where that was what these were the components that federal agencies had to have in terms of meeting the requirements for leading the way for drug-free workplace programs in the public and the private sector. So it's a written policy, which is the foundation of your drug-free workplace program. Employee education for employees at all levels to be prepared for the implementation of your policy and program. They need to know about the problems associated with substance misuse in terms of their own safety, their own productivity, but also the safety and productivity of their coworkers, and ultimately also in terms of their customers or their clients or their end users. Supervisory training is key to help maximize the effectiveness of your drug-free workplace policy and your programs. They need to know what your policy is, what their responsibilities are as managers or supervisors. And I tend to think, although I'm not sure how much progress we've made in this area over the years, but I really feel that supervisors are the first line, if you will, for intervention, that they need to be able to recognize signs and symptoms of someone who is at work under the influence of alcohol or drugs. Maybe it's under the influence of medications that they are prescribed. But the issue is that they need to be able to see where those things are occurring and be able to intervene to find out whether or not this person can safely perform their duties, again, without being a risk to themselves, to their coworkers, or to the people or clients or customers that their workplace serves. Drug testing was mandated in the original federal executive order and the resulting public law. And then again, of course, in Nuclear Regulatory Commission, DOT and other regulatory agencies, that was a way to protect the workforce from the negative effects of substance abuse or misuse. That we found later on that insurance carriers, for example, recognized that companies that implemented a drug-free workplace policy and that could enforce that policy through drug testing, in fact, were able to lower their accident rates, their incident rates, certainly their medical benefits usage rates, a whole bunch of things that were of benefit to the insurer as well as to the company. And so that's when many insurance carriers provided discounts, reduced rates, or in fact, rates were higher for a workplace that did not do any drug testing, that did not have a drug-free, comprehensive drug-free workplace program and policy. And then the final component, and I'm not saying that these are in any order of significance necessarily or importance, they all work together as to form a comprehensive strategy, is employee assistance programs. And they are designed to help employees with personal problems that may affect their job performance. Although some EAPs focus on problems related to alcohol and other drugs, most address a range of issues and can provide a variety of services. And so there are other stressors for employees, not just drugs or alcohol. And it may not be just the employee's own drug or alcohol use or misuse, but their family members or their close associates that are impacting their ability to perform their job safely and and at their optimum abilities because of having to deal with substance abuse. It's no secret to any of you, I'm sure, that the research, again, longitudinal research over 3 decades, has identified 5 areas in which substance abuse really measurably impacts workplaces. One is in absenteeism. A second is in retention and turnover of employees, of staff. A third is in workplace incidents of violence or of theft or of other kinds of things that occur. A fourth area in which is our workplace accidents that include injury or substantial damage to property. And the fifth thing that we know is that in workplaces that do not have a comprehensive drug-free workplace policy and program and drug testing to enforce and undergird that the risk-taking behaviors of employees who are drug or alcohol abusers is much greater. So that results in more safety rule violations, more, quote, near miss, if you will, incidents, etc. And that's been sustained over decades of research. So there is definitely a nexus, if you will, to those measures of the, quote, health of a particular workforce or a workplace. So what are the objectives and goals of a drug-free workplace program? Certainly prevention, safety, and intervention, I think, as an overall paradigm, if you will, for what we're trying to accomplish. We want safer, more productive workforces to reduce workplace accidents and injuries, reduce workplace violence, reduce absenteeism and employee turnover, increase worker productivity, and to facilitate improved employee morale. Again, I can remember some of the early data from the annual surveys that are done by NIDA or by the Substance Abuse and Mental Health Services Administration, et cetera, talking about employee perception of working in a workplace that had a drug-free workplace policy, where drug-free the facilitation of a drug-free workplace was a central part of what the employer was committed to, that they preferred to work in that kind of a workplace. They felt safer. They did not feel that there was there was not a negative impact on worker morale, but in fact, it had the opposite effect. Deterring drug and alcohol abuse among the workforce is certainly another objective and goal of a drug-free workplace program. Communicating that illicit drug use, prescription drug abuse or misuse, being at work under the influence of alcohol or drugs is expressly prohibited. That's prohibited conduct. And that is a key thing in terms of establishing the expectations. And that expectation that employees are drug-free, and I'm using drug here to include alcohol, that they are drug and alcohol-free while they are at work, and that you can deter drug and alcohol use among workforce by communicating effectively that there are employment consequences for violations of the policy, whether that is termination, whether that is suspension, whether that is mandatory referral and evaluation, whatever it may be, that there are consequences associated with violations of the policy. And then after deterrence, detection is that is a goal of a drug-free workplace policy, to detect employees who are at work under the influence of drugs or alcohol, so that, again, not only is it an intervention strategy, but it's a tertiary prevention strategy, so that if you can detect employees who are at work under the influence before they cause an accident, but before they're involved in a workplace incident, etc., all the better. So it's to protect workers from coworkers who are impaired at work, and a risk mitigation strategy overall for the company, and that that supervisors and managers have a responsibility, part of their responsibility, to ensure that the workers who are there, who are under their care and supervision, are not impaired at work. And of course, the last thing is that it does serve, as I mentioned, an early intervention and a tertiary prevention tool for substance abuse disorders. If we can identify and encourage self-identification and use of the employee assistance programs, getting help earlier is always until earlier in the cycle, if you will, of abuse and dependency, it is always a better outcome. And again, it can and should interrupt the cycle of trial use, problem use, abuse, and ultimately dependency or addiction. It is truly amazing to me over the years, and I haven't been involved in clinical treatment services for a long time, but even then, when I was prior to getting involved in the policy end, I was involved in treatment for both adolescents and treatment programs for U.S. military personnel and their families, or their dependents, as they were called at the time. And over again, there was a substantial percentage of people in those treatment programs, be they residential, be they outpatient, or whatever, that said that had it not been for the intervention at work, in terms of from a supervisor or a manager, or failing a drug test, or whatever it may have been, that probably they would not have gotten the help that they needed and being able to turn their lives around. And even when the work I do now with impaired health professionals, that's what I hear when you have a person, a doctor, a nurse, a pharmacist, whatever, that has gone through a 3 to 5 year monitoring program after treatment for substance use disorder, be that alcohol or other drugs. And when they successfully complete that program at a 3, or most of them at a 5 year mark, where they have had to, for that 5 years, they've had workplace monitors. Their license has often been restricted or suspended, so they're working in a different part of the healthcare complex. And they have been subject to drug testing on a regular basis. And by regular, in some cases, it's weekly testing. In some cases, it's monthly testing. And I'll talk about that at the end. But anyway, and they have to go to 12-step meetings. They have to have weekly meetings with a mentor or with a supervisor concerning their recovery status. But when all of that is done, and when you ask them, what was rank order, which of these interventions, which of these portions of your recovery monitoring program in the Florida State Board of Nursing Program or the Washington State Federation of Physicians, Recovering Physicians Program, what was the most significant thing? What do you think helped you to have 5 years of success of abstinence from drugs, of being able to, to address your substance use disorder? And over again, they said that being subject to random, unannounced drug and alcohol testing, so that I could never plan a relapse, so that I had to recognize that that kind of action on my part would in fact cost me greatly. And so they felt that that was even more significant than competing or being involved in 12-step groups every day or every week, or being involved in other kinds of treatment aftercare programs. Okay, so you can tell that I do believe that drug testing and alcohol testing is a very essential component of an effective drug-free workplace policy, of an effective drug-free workplace component. I think it is the one objective kind of tool that we can use to both deter people from using drugs or alcohol in proximity to their work, and secondly, to detect those who are using drugs or alcohol that would impact their ability to work safely and drug-free. All right, so who to test? And these are things that you've probably already answered in terms of in your program or your policy, but I just wanted to review them a little bit. We've had some experience now over the years with the thousands of workplaces that have drug-free workplace programs and that implement some type of drug testing as a policy program enforcement tool. Should you test all employees? Well, if that's what you're deciding, that we're going to test everybody from the administrative staff to the janitorial staff to the financial staff, it's got to be everybody. You can't just say, well, we're only going to test hourly employees, or we're only going to drug test salaried employees, or, well, we definitely don't want to have to test our salespeople. We definitely don't want to include our CEO, our CFO, or COO, or whatever. So you have to be able to say, okay, if we're going to test all employees, it's all employees. If you're going to limit your testing to safety sensitive positions, which is an acceptable thing, and which probably close to 30% of workforces that don't fall under federal regulations or whatever, that's how they decide to implement workplace testing, drug and alcohol testing, is that they limit it to safety sensitive positions, particularly for random testing. They may do pre-employment or applicant or candidate drug testing of all candidates for whatever position, but their ongoing incumbent employee drug and alcohol testing is limited to safety sensitive. And then that's up to you to define. There's no magic thing. I mean, it can be anybody who operates any kind of vehicle or any kind of machinery, who works in any kind of a hazardous environment within your work site. It can be people who have direct care responsibilities to children, to patients in a healthcare setting, to vulnerable, any kind of vulnerable persons, etc. It can be emergency response personnel. If you've got, again, large warehouse operations and you have people that are on the roster, if you will, for when there is an emergency in that warehouse, even though normally they are sitting in the accounting office or whatever, because they have emergency response responsibilities, they are and can and should be considered safety sensitive, so that if you're testing safety sensitive employees, they should be included in that category. Fiduciary fiscal operations, that's also another area that many employers include for ongoing drug and alcohol testing. Accountants, financial transactions employees, clerks, etc., banking employees, sales and marketing, etc. You might be interested to know that one of the very, very first industries that did comprehensive drug testing was actually the gaming and casino industries. Now, why would you think that? That doesn't sound very safety sensitive, but it was because of what the casino industry, the gaming industry felt were risks relative to handling financial transactions, handling a lot of money, all of that kind of thing, that there was good reason to enforce a drug and alcohol-free workforce for the casino industries. And so they have done that since the beginning of the 80s, far ahead of many other industry sectors. I've always found it sad, to be honest with you, that the two sectors in workplaces that were kind of the last or the least likely to adopt strong drug-free workplace programs and policies that included drug and alcohol testing as, again, a way to enforce and to facilitate the successful implementation of the policy were the healthcare industries. Interestingly enough, education, school boards, school districts, have resisted for years drug and alcohol testing of teachers, except under very, very narrowly defined reasonable suspicion or for cause testing. The other industry is the tech industry. They're very, very little drug-free workplace policies that were in the tech industries in the early 90s. They have come to some extent a little bit further than they did before, and I thought it's so interesting to me that those areas, healthcare, education of children in particular, the tech industry, that they would not see the benefits to their bottom line, to their risk mitigation in terms of having an effective drug-free workforce, drug and alcohol-free workforce. Okay, so what should you test for? Certainly my recommendation is that at a bare minimum, you should test for Schedule 1 and Schedule 2 illicit drugs. And those, those drugs are things like, like fentanyl, like heroin. Marijuana is still there. Cocaine is another example. Methamphetamine is another example. So basically, for the illicit or illegal substances, even though in some cases, some forms of, for example, methamphetamine may be prescribed so that they do have some legitimate medical use, but that's absolutely in the minority. Most of the methamphetamine that is available in this country today is illicit D-methamphetamine that is produced in clandestine labs and that is not pharmaceutically manufactured or pharmaceutically distributed. You can and should consider expanding your drug testing panel to include controlled substances on Schedule 1 through 5. So that would be the illicit drugs. That would also be controlled substances that have psychoactive impact on both cognitive and motor functioning. And so that would include drugs like benzodiazepines. That would include drugs like all of the opioids, such as hydrocodone or hydromorphone. That would include a number of controlled substances that are prescribed for depression, that are described for ADHD, etc. Why should you test for that if you know that people will probably have a prescription for it? That's fine, because then you would have a medical review officer that would review that test result and ask the person, do you have a prescription for any of these medications that would cause this positive test? And that's an opportunity, again, when they're talking with that physician about how much of the drug that they take, when do they take it, and depending on what their position is, if they're operating machinery, they're driving a vehicle, it's an opportunity for the medical review officer, while reporting their tests as negative because they have a prescription for it, to also raise a safety concern, so that then you, as the employer, can say to that employee, I need to get you clearance. You need to get clearance from your doctor that while you're taking this medication as he has prescribed it or she has prescribed it, you can safely perform the functions of a forklift operator, or you can safely perform the functions associated with the operation of machinery or the agricultural loading in a warehouse, etc. And then I do think that you should test for alcohol. I am not convinced that you need to do random alcohol testing. And part of the reason that I say that is it's much more difficult to test for alcohol than it is to test for many of the drugs. You really cannot use a urine specimen to test for alcohol. You cannot use a you cannot use an oral fluid or a oral swab to test for alcohol very effectively, because it does have to be confirmed in terms of saying exactly how much blood is in the person's bloodstream at the time the test is taken. So alcohol testing, I think, by and large, what most companies find successful to try to deter and detect people being at work impaired by alcohol is to do an alcohol test, a breath or a blood test, when there is a workplace accident or incident involving personal injury or significant property damage, or when there is reasonable suspicion that a supervisor or a manager has identified some signs or symptoms associated with alcohol on board. That can be the odor of alcohol and alcohol impurities on the person's breath. That can be, staggering gait. That can be slurred speech. That can be bloodshot eyes, any combination of those things. And I've always tried to teach supervisors, in terms of training them for reasonable suspicion testing determination, that their goal is to identify signs and symptoms that may be consistent with having alcohol in their bloodstream, and then doing the test to rule out whether or not they are under the influence of alcohol. That's the primary goal of a reasonable suspicion test. It's not necessarily to see how impaired they are, or whether or not they are an alcoholic, or when they have. It is to rule it out. So a negative test is accomplishing the goal or the objective, which is to make certain that what you see, hear, or smell is not because of having alcohol actively in the bloodstream. When should you test? Well, certainly in the state of Florida and in most states in the U.S., not all, but in most, it is acceptable for employers in the private or public sector to test applicants, to drug test applicants. Doing an alcohol test for an applicant is a little trickier. You would have to make a specific job offer in order to require a candidate at that point to undergo an alcohol test. And it would have to be a breath or a blood test. And even then, there is some difficulty sometimes in being able to use a candidate alcohol test because the person isn't actually working for you yet. They're not performing safety sensitive work. They're not at work with alcohol in their system. And so I'm not one that is going to really suggest that an alcohol pre-employment or candidate test is an effective measure in terms of your policy. Reasonable suspicion, you should definitely have reasonable suspicion or for cause testing as part of your program. Post-injury or post-accident testing, again, well-defined, not after every little slip and fall, or not after necessarily when somebody bumps their elbow or whatever it may be, but really defining under what kind of accidents or incidents is there a significant injury to any individual. Does the person, the employee, could their behavior or could their actions have contributed to that accident or to that incident? Return to work. There are many companies that if a person is off work for more than 30 days or perhaps more than 60 days, whether that's for an administrative leave, whether that's for FMLA, whether that is for a medical treatment or whatever, that when they return to work, they must pass a drug test. And again, the courts have upheld this kind of testing. If it's stated in your policy and your rationale is to ensure that the individual returning to work is not misusing or abusing prohibited substances. Post-rehab, if the person goes through your EAP, or through a treatment program for a substance use disorder, it's strongly recommended that upon their return to work after treatment, that you should do follow-up and periodic testing to ensure that they are remaining abstinent from the drugs or the substances for which they received treatment. Random testing. I am a big proponent of random testing, and you don't have to test every week. You don't have to test every month. I'm going to give you some strategies of incorporating random testing into your program in just a minute that we've been able to accumulate some data on in terms of the impact and the effectiveness of it. And then incident-related testing, you can certainly do that. There are some programs that have in their policies that if there is an incident where drug contraband is found in public areas or in common areas in a workplace, that anybody having access to that area can be required to undergo a drug test, for example. Again, that has to be pretty well prescribed in your policy in terms of what kind of an incident is going to trigger drug testing of multiple people, if you will, multiple employees, and for whom there is no individualized reasonable suspicion. Okay, so there are more options than there ever have been for doing effective and efficient, if you will, drug testing in support of your drug-free workplace policy. The historical precedent has been to use urine drug testing, and for alcohol, excuse me, to use blood and breath testing. Oral fluid testing, saliva testing has come on the workplace scene in recent years, over the past decade approximately, and it has been approved for drug testing in federal programs. We're still waiting for one piece of that implementation to get in place, which is the certification of drug testing laboratories that are going to test oral fluid or saliva specimens. All of the federal testing requires that you have to use a federally certified or approved drug testing laboratories. And currently, we do not have any laboratories that are federally certified for doing oral fluid drug testing. There are many laboratories that do it and do it well, but they have not completed the National Laboratory Certification Program process for being certified to test oral fluid for drugs of abuse. Urine, oral fluid, and hair and nail testing, by the way, have increased in usage, particularly for applicant drug testing, because, and we'll get into the reasons for that, but there are some amazing statistical studies that are available now of employers that are doing pre-employment hair testing and drug testing with using a hair specimen, in terms of comparing that to when they do a urine specimen as a pre-employment drug test, and what the differences are in positivity rates, in identification rates, and the impact later on in terms of how much doing a hair test at the beginning of a person's employment actually does serve as a deterrent for their using drugs once they are employed at in that workforce. So the testing methods that we'll go over real quickly: urine, oral fluid, and hair and nail testing generally involve laboratory analysis. Most of you are familiar with that. That the specimen is collected at the worksite in a clinic or at a laboratory patient service center. That there's chain of custody documentation to ensure the proper identification and security of the specimen. Specimens are shipped then to a laboratory for analysis, and the laboratory procedures employ a two-test process, whether that's hair, oral fluid, or urine. It goes through a screening process or an initial test process, and then only then, if it is presumptively positive on that analytical method, is a second portion of that same specimen submitted to confirmatory testing, which is done by some combination of mass spectrometry and chromatography. There are many workplaces that employ the use of what I call POCT, which is point of collection testing. These are rapid or quick tests where the specimen is not tested at the laboratory and it gives a preliminary immediate result. The problem with that is that while it may be less expensive and it does give you a rapid result, both the false positive and the false negative results, depending on the specificity and the sensitivity of that point of collection device, really play into how much you are able to accurately identify about that employee or that applicant's drug or alcohol use. Certainly any presumptively positive tests on a rapid test, in order to take an employment action, whether that is not to hire or some other type of employment action, such as termination, you absolutely must get that drug confirmed in a laboratory using mass spectrometry. Otherwise, it will never, ever, ever hold up in court or to any kind of legal challenge. Okay, so workplace, I talked about breath and saliva and blood. Saliva testing can be used for alcohol as a screening. And again, if that is positive, then you need to confirm that with either a breathalyzer result, an evidential breath testing device, or with a blood draw, with a blood alcohol. Okay, let's see. How much time do I have, Heather? A few minutes?
We are a little bit over the hour, but I would say if you can hit these last couple slides real fast, I'm sure people are still with us, so
Okay,
they
all
I'm
right.
sure they're
let me
still
do that.
interested.
All right, so in developing a strategy, one of the things that you need to know about that you've got all these options, but one of the things that is central to how you would develop that strategy and put that testing program together is what are the windows of detection. So you can see that for oral fluid, for example, for most drugs, and we're talking about the controlled substances that we've mentioned earlier, most of those are going to have a window of detection in a saliva specimen for between 1 and 3 days. Again, it does depend on the drugs. Some drugs like methamphetamine and cocaine wash out much more quickly out of the oral fluid than do, for example, opiates or opioids. Urine is going to have a window of detection for most drugs except for marijuana of about 1 to 4 days, 5 days, maybe in terms of benzodiazepines, etc. For urine testing for marijuana metabolites, if a person is a regular, frequent user, let's say 3 times or more a week, and has done so for a month or more, it is possible that we will find the non-psychoactive metabolite, the tetrahydrocannabinol, in their urine specimen for up to 21 days after their last use. But for an occasional user, that urine specimen is only picking up marijuana or cannabis use for approximately 3 to 5 days after they used it. Let me mention here real quickly about marijuana. If a person is using CBD products, I don't care whether that's tinctures or oils or lotions or gummies or blah, 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 blah. CBD is not going to cause a positive marijuana test. Now, if they are getting CBD off of foreign markets, for example, where there may be a much higher concentration of the tetrahydrocannabinol, the psychoactive component, but if it is legitimately manufactured in the US and distributed in the US, it can not have more than 0.3% THC, and that's not going to be enough to trigger a positive test. Head hair will give you approximately 90 days of look back, and likewise fingernails, slightly longer, about 3 to 4 months, since you know that it will look back for any use in that period. Body hair, not head hair, but body hair from the arms, from the legs, from the chest, from the armpits, etc. Again, because of the slow growth rate of that hair, is going to give you a look back of 4 to 5 months. And then toenails give us the very longest because they have the slowest rate of growth. They have the largest deposit of keratin, in which drugs are readily and easily deposited and stay there. Okay, so that's the window of detection thing. I think most of you are familiar with this. This is just a really quick view of the collection supplies for getting a hair specimen. This tells us most of the things that you want to know about how drugs get into hair, and it's much smaller amounts of drug that are deposited in the hair follicle or in the hair shaft than you find in the amount of drugs that are deposited in that are present in the urine. And that's why we test not to the nanograms, but to picograms, which is 1,000th of a gram. So it is, it is a very, very sophisticated process. Again, it uses mass spectrometry and chromatography. And the drug testing laboratories are able to do a lot of work up front to distinguish between a person that has actually ingested drugs as opposed to been environmentally exposed to them, being in a room where somebody smokes marijuana or vapes methamp or whatever it may be. And then the other thing that you need to know is that hair testing always is really, if it's positive, that is consistent with multiple episodes of use over that time, that window of detection. A person who, who does a single line of cocaine on one occasion in the past 3 months is likely not to have a positive hair test or a positive nail test. But the person who has repetitive ingestion of cocaine, of methamphetamine, of marijuana, of opioids, of whatever, that is going to show positive. We won't be able to tell how many times, and we won't be able to tell when they last used it. Was it a month ago, or was it 2 months ago, or was it only 2 weeks ago? We do know that from the time that the person uses the drug, it takes 7 to 10 days for that drug to diffuse through the bloodstream into the to be deposited in the shaft or the follicle of the hair. These are the devices that are used for lab-based oral fluid testing. As you can see here, the real advantage here is that these specimens are essentially self-collected. You don't have to have a specimen collector, goes into the bathroom and does all this, does the chain of custody. They give the person, it can be a hiring individual, someone at your workforce, you give the person the sealed swab kit. They put it in their mouth, okay, themselves, keep it in there until enough saliva has been absorbed onto that pad that you see. They then insert the pad into a vial or a tube that has a buffer solution, hand it to you. You identify that vial or that tube with again a sticker or a label that identifies that swab as the person's, goes off to the lab, and it is tested. So it's a much cleaner, if you will, less invasive in many ways than trying to do a urine test. This just tells you that, again, the same procedures are followed in the laboratory for testing a oral fluid specimen as in urine. You have a screening test and for various analytes that are on the drug panel. And then if that is presumptively positive, it goes on for a second aliquot or small portion of that oral fluid that's in that vial, that tube. And it is confirmed then by mass spectrometry. Passive exposure and environmental contamination do not contribute to an oral fluid drug test. I think this is the technology that is soon going to overtake, in some ways, urine drug testing in the workplace, because it is easier and because it is not subject to being adulterated or subverted in any way like urine testing is, with all the fake urine that's out there, with being able to dilute the urine specimen so that the concentration of drugs in the specimen is less than the cutoff levels. All of those kinds of things are really mitigated, if you will, by using an oral fluid specimen for drugs. And one last thing about this is that if you are concerned, even in the state of Florida, where we don't have recreational marijuana use legalized yet, but we do have a lot of medical marijuana. If you are concerned about only identifying people that are using marijuana in close proximity to being at work, by that, I mean within the last 24 to 36 hours, and we know from research that if they've used marijuana 24 hours earlier, that we will find the psychoactive component, and that for most people, there is some measurable impact on their cognitive or their motor functioning. If you use an oral fluid test as opposed to a urine test, you are only going to identify the active metabolite. And so that, the person can't say, well, look, I've got this medical marijuana card and I never use it before work. I only use it, da, 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 da. Your oral fluid test says, you know what? You use that marijuana within 24 hours of coming to work. We expressly prohibit you from being at work with psychoactive a drug in your system. Therefore, that's a violation of our policy. So that's another little thing to consider as you use it. Urine testing, I'm not going to go over a lot. We're short of time, and I know you're very familiar with that. I've done this chart, and Heather, they're going to be able to get a copy of this, aren't they?
Absolutely.
Okay. So you can, here's where I have and I've touched on most of these things in terms of trying to compare and contrast the three major options that you have in terms of ease of collection, the integrity, accuracy, and reliability. And then at the bottom, I even put in some data about the cost and the logistics, if you will, of comparing urine drug testing to oral fluid drug testing to hair or nails drug testing. So where does that bring us now that I've talked longer than I should have? But I would encourage you to at least consider mixing things up in your testing program. Don't just limit it to urine testing. Maybe you do a hair or a hair test as a pre-employment test. And then maybe rather than doing random selections every month or every quarter, that you do random hair testing, maybe once maybe every 6 months. Throw it in together so that you're really covering your window of detection issue, and it does act as a better deterrent, if you will, to use. So were there questions in the Q&A that I need to look at?
Thank you so much for that, Dr. Donna. Especially this last bit about the comparison. I think people will be really excited to have this so they can reference it in the future. We don't have any questions in the Q&A just now, but if you're okay with it, I'll pass along your contact information as well as these slides to our attendees so they can reach out. They can reach out to myself. They can reach out to you as well if they have any further questions or want to ask anything else.
Sure, that'd be fine. Okay, well, thanks for participating and hanging in there for an extra 15 minutes, okay? Take care.
Thank you all.
Bye-bye.
We'll see you next time. Have a wonderful rest of your day.